Well, let's go ahead and get started, and good morning everyone, and welcome to our Grand Rounds. And I think it's great to introduce our speaker for the day, Dr. Barry TRACHTENBERG. He is one of our own, and also actually he is one of the few Houstonians that are here. Grew up here in Houston and is our heart failure specialist with interest and focus on cardio-oncology, a field that is really growing. And I can tell you how important it is becoming, because even at the ACC, there is now a council for cardio-oncology, and there are symposia every year regarding that. So I think it's going to be a very important update for us to talk about our own cardio-oncology program, where we're heading. Barry went to medical school in University of Texas in San Antonio, did his medicine residency here at Baylor College of Medicine, and went to do his advanced heart failure and transplantation training at the University of Miami. And we were fortunate to get him on staff, and is an amazing leader, emergent leader in advanced heart failure and cardio-oncology. And his interest is not only in applying our cardio-oncology program, but also doing research on conceivably what could be the genetic determinants of this disease, and so collaborating with several institutions to give us and shed more light onto, one, how can we prevent it, two, part of its pathophysiology. So today it will be an overview of cardio-oncology, and Barry, it's great to have you to tell us before the holidays of what is the field of cardio-oncology. Great to have you, so welcome.
Thank you, Dr. Zoghbi, for the kind introduction. And today we'll just kind of give you an update in the field and a little bit about what we're doing here at the program. Some disclosures, I do plan on using some big words that some people might find offensive, such as evidence-based, science-based, and other words that our Department of Health and Human Services don't wish us to use. So we'll start with the case. This is a 63-year-old woman who has a history of hypertension, a left bundle branch block. She had diffuse large B-cell lymphoma, treated at a neighboring cancer facility with lenalidomide, ibrutinib, and R-EPOCH, which is rituximab, etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin. She had 8 cycles, 7 cycles at the time, at this time, so a total of 300 milligrams per meter squared of doxorubicin at this point. Her baseline echo was normal left ventricle size, EF was 64%. And she had a left bundle branch block, so her cardiologist ordered a calcium score pre-chemo that was 0, so they felt comfortable she didn't have coronary disease. 2 months prior to presenting here at Methodist DeBakey, she had an EF of now 50% and a change in her global longitudinal strain of negative 14.6, with negative 18 being the cutoff. She was given Coreg, was told not to take if her systolic blood pressure was less than 100, which was frequently the occurrence, so she didn't take the Coreg very often. Despite the fact that her EF dropped 14%, she was given another cycle of R-EPOCH, so she had a total now doxorubicin of 360 milligrams per meter squared. And then she presented, she was referred to Dr. Quinones, and he noted that she was having dyspnea. When he was getting the history from her, he noted an S3 gallop, and then he called us and had her admitted for heart failure. She has a left bundle, and then her EF was in the 20s, and she was in extreme heart failure at the time that we saw her. So it's easy to know what to do at this point. We don't give her any more chemo if we can avoid it, and treat her heart failure, which is what we did. But the more question is, what do you do when it gets to 50%? And it's a very common occurrence that patients will have a 50% EF, which is a drop of 14% in her case. And it actually wasn't ignored here. Oftentimes it's ignored. People think, oh, it's still normal, not to worry about it. But here it was actually noted, and she was still given more chemo. And she was not really appropriately treated because she wasn't given the Coreg most of the time. So this just exemplifies kind of a common type of patient that we see And she ended up doing well. We put her on ACE inhibitors, beta blockers, carefully titrated her. EF's now in the 40s, and she's in New York Heart too. So she's doing well. This is just to give you an idea of the scope of the problem. The good news is patients are surviving much longer from cancer. So if you look at projected by 2020, it'll be almost 18 million patients that'll be cancer survivors in the U.S. And this represents about 4% of the general population in the United States. It's an extraordinary number. And patients are not only they're living longer and longer. So 64% of survivors have survived 5 years or more after diagnosis. 41% survived 10 years or more. And if you look at children, which we can watch over longer periods of time, they're 8 times more likely to die of heart failure or die of heart disease, and 15 times more likely to experience heart failure than their age-matched contemporaries without cancer. So it's an extraordinary amount of patients that we're going to be seeing that have cardiac complications from cancer therapies. And if you look at the two leading causes of death, clearly heart disease and cancer are at a race to the top, and cancer is certainly increasing. And as the longer these patients, the more patients have cancer and survive, more and more will have heart disease. So they are very much tied together. Similarly, when we look at the causes of death among breast cancer survivors, you can see that once you get past 10 years, that cardiovascular disease becomes the #1 cause of death as opposed to breast cancer or other cancers. So what is the role of a cardio-oncologist? So one is to pre-cancer therapy or radiation therapy. You want to assess their baseline risk. You want to address any modifiable risk factors, including hypertension, hyperlipidemia, et cetera. And you want to, at that point, develop your monitoring strategy. Knowing what they're going to get from what type of therapy they're going to have will decide, and what risk factors they have will kind of decide your monitoring strategy at that point. While they're getting chemotherapy or radiation therapy, you want to monitor them for cardiotoxicity. You want to really facilitate their treatment. You want to not try to have them avoid getting chemotherapy. You want to really allow them to get chemotherapy, but as safely as you can from the cardiovascular perspective. You want to continue to address any modifiable risk factors and or side effects from medications, including hypertension. And if they do have any toxicity, you want to start appropriate therapy as soon as possible. And then depending on what their prognosis is from the cancer standpoint, and depending on what the cardiovascular toxicity is, you want to discuss what the next strategy is with your oncologist. And then post-cancer treatment, you want to continue to modify risk factors. You want to educate patients on their long-term side effects, manage any toxicities, and then the role of long-term surveillance, which is really not clearly established or defined in terms of what that means. But this is from a recent state-of-the-art paper in JACC with Edward Ye, formerly at MD Anderson as a senior author. And this just gives you an idea of not only the breadth of chemotherapies that are causing cardiotoxicities, but also the different types of cardiovascular toxicities that come from different chemotherapeutic agents. And it's really an extraordinary amount. And it's a very not so well-known secret that cardio-oncologists are frequently looking up these medications as they come out. There are new medications come out every few months, and it's very hard to keep up with. So if you look at this slide, this is just medications that are associated with heart failure. And you can see, in addition to doxorubicin and other anthracyclines, which are kind of the quintessential example, there's a number of agents. You can see your alkylating agents, tyrosine kinase inhibitors, and proteasome inhibitors, et cetera, a multitude of agents that cause heart failure with incidences that you see here. In addition to that, there's other agents that cause ischemia or myocardial infarction. So you have the classic example of 5-FU, and it's prodrug, a little bit less common. And then you have the monoclonal antibody-based tyrosine kinase inhibitors, the small molecule TKIs, and other drugs that can cause ischemia. And there's more. Hypertension. A large number of drugs cause hypertension, and patients on these drugs need to be carefully managed and screened for hypertension and monitored while they're getting therapy. Additionally, there's agents that cause QT prolongation. You have to monitor these patients with EKGs and potentially change doses if they have moderate or severe QT prolongation. And then finally, there's agents that cause thromboembolism. So you can see agents here, alkylating agents, monoclonal antibodies against VEGF, such as Avastin, and then small molecule TKIs are very commonly will cause thromboembolism, in addition to the risk that they have just from their cancer. So going to anthracyclines, which is the bread and butter of cardio-oncology, it's the clinical heart failure is found in about 1 to 5% of patients that are treated with adriamycin, and asymptomatic systolic dysfunction in about 5 to 26%. Toxicity, however, can even occur at low cumulative doses. So you see here, even at less than 250 milligrams per meter square, in the red, there's still a not insignificant amount of cardiotoxicity. This is a recent paper that came out of Italy that really gives us a good idea in a contemporary fashion on current typical doses, what the incidence might be. And this, I think the study is one of the most informative in that regards in the literature, because if you look at the literature, the incidence is anywhere from 1% to 26%. So this is from over 2,600 patients from Italy that were getting any anthracycline-based protocol, but it excluded patients that were getting high doses, more than 400, and those that were getting concomitant Herceptin antagonist. And the median follow-up was about 5 to 6 years after their last chemotherapy. Cardiotoxicity was defined in a pretty robust fashion as an EF drop of more than 10% from baseline and the EF less than 50%. So it's a pretty good cutoff. Some studies will use 55%. This is using a pretty conservative cutoff. And if you look at the characteristics of the patient that had cardiotoxicity, they really didn't receive that high of a dose of anthracyclines. But cardiotoxicity occurred in 9% of patients, 226 patients. Those getting breast cancer, which are mainly women and the mean age was 51, so not high-risk patients, 9.7% of those patients with breast cancer had cardiotoxicity, and 6.2% with those with non-Hodgkin's disease. So it's really, for how common breast cancer is and how many of these women don't have high-risk factors, this is an extraordinarily high number that have cardiotoxicity, and a lot of this probably goes unnoticed if they're not being monitored in a cardio-oncology program or a sophisticated program that is checking and looking. And what's interesting, where anthracycline cardiotoxicity was long thought to have a delayed diagnosis or delayed effect, in this study, 98% of these patients had the cardiotoxicity occur in their first year of chemotherapy. So this study is really insightful in terms of a prospective contemporary series showing not only is the incidence higher than we thought, but also that it occurs early. So what is the mechanism of anthracycline cardiotoxicity? For a long time, we really only had the reactive oxidative stress theory to hang our hat on. And you see here with the quinone moiety of anthracyclines, there you have free radical formation and oxidative stress and downstream damage. What Ed Ye from MD Anderson discovered is, one is anthracycline is a topoisomerase inhibitor. And topoisomerase helps your DNA unwind and wind. And if you inhibit that, it causes more DNA breakdown. But the heart, he discovered, has a lot of topoisomerase type 2 beta. So if you inhibit that in the heart, it can cause DNA damage, and it can actually cause reactive oxidative stress as well as mitochondrial damage. So this may be the explanation for the mechanism of anthracycline cardiotoxicity. What are the risk factors for anthracycline cardiotoxicity? We talked about cumulative dose, and certainly it can occur at any dose, but certainly the higher the dose, the more possible and likely it is. The length of post-therapy survival, so children certainly at higher risk. So extremes of age, children less than 4, adults over 65 are at higher risk of having risk of heart failure. And there is some data to suggest that there's a continuous infusion as opposed to a bolus might decrease the peak anthracycline and might decrease the toxicity. That's been, in pediatrics, that evidence didn't pan out. In adults, there's some very soft evidence that suggests that, but it's not clear cut. And in addition to that, the type of anthracycline, so if you put a liposomal derivative of anthracyclines, that is shown to reduce cardiotoxicity. And radiation therapy increases cardiotoxicity, if concomitant radiation therapy, or concomitant other chemotherapies that can cause heart failure, such as Herceptin and cyclophosphamide and others. Certainly pre-existing risk factors, cardiovascular risk factors, also increase the risk of anthracyclines, and genetic determinants are being investigated, including here at Methodist. So how do we screen and detect for anthracycline cardiotoxicity? So all the guidelines, American Society of Clinical Oncology, Heart Failure Society of America, and AHA, they all recommend serial assessment of your ejection fraction. None of these recommend specifics in terms of what modality to use or how often to check them. So really not many centers are using MUGA these days, but surprisingly there are some that still use it pretty frequently. Echo has obvious advantages. One, there's no radiation, it's cheaper. You get additional information, including hemodynamics, valvular disease, diastolic dysfunction. And then there's newer techniques that have been additive in terms of predicting cardiotoxicity, specifically global longitudinal strain, and 3D volumetrics have also been shown to be helpful. The limitations of echo, as we all know, there's inter-observer variability with an LVF assessment of 5 to 10% of the absolute value of the EF. So we often get calls from the oncologist, well, you got an echo, this day it's 55, the next day it's 60, what's going on? And then also the abnormal EF is really a late finding. Ideally we'd have other biomarkers or other methods of detecting damage before we actually see the heart on an echo with gross dysfunction. So strain, as we all know, is a dimensionless index showing the total deformation of the myocardium during a cycle as a percentage of the initial length. And what we know is that change in GLS typically occurs before the onset of LV dysfunction. So this is just an example on the bottom screen. You see the patient with still preserved ejection fraction, but has a change in his GLS from -20 to -17. And then a few weeks later, he has a drop in EF. That is not an uncommon occurrence. Here at Methodist, we've been trying to get strain in every patient that's undergoing chemotherapy with pretty good success, not perfect, but I'd say upwards of 80 to 90% of the patients. And we use a GLS based on the literature of greater than -18, and we use a change of 12% from the prior echo to consider that worrisome or to act upon that. If we see a change in strain and it looks like it's appropriate, we will consider ACE inhibitors at that time to prevent cardiotoxicity. The negative predictive value of strain is very high, as you see from this state-of-the-art review in JACC, in 90s predominantly. The positive predictive value is a little more modest in the 50s and 60s, so it has a better negative predictive value. In addition to echo, the use of biomarkers has been studied, specifically with troponin and BNP, as well as others. This is a study that looked at 473 high-risk patients on high-dose anthracyclines, also from the Italian group, Cardinali et al. So they had 114 patients out of these 500 that showed a troponin that was positive, and they randomized those that had a positive troponin to receive enalapril at 20 milligrams a day or placebo. So you see in the figure on the left, these are patients that were in the control group. On the right, these are patients that had ACE inhibitor. In the white squares, these are patients that had a positive troponin, and the black are those that did not have a positive troponin increase. If you see that those in the control group, whether or not they had a positive troponin, you can see a decline in EF there, but certainly more prominent in those that had a positive troponin. Whereas those, even if they had a positive troponin and received an ACE inhibitor at 1 month, they had a preserved ejection fraction. And you see that LV dysfunction in the control group, in the ACE inhibitor group there were no patients with LV dysfunction, whereas 43% of patients in the control group had LV dysfunction. And cardiac events were also similarly much, much higher in the group that did not receive ACE inhibitors. So this it tells us, at least in patients that have a positive troponin during chemotherapy, that they would benefit from an ACE inhibitor. And really, screening is so important to be done in real time, because if you treat these patients early, you really can reverse their cardiotoxicity. So specifically, this study, within 6 months, if you're able to start them on therapy, they're able to improve their function and respond. But most patients after 6 months have not been able to do so. So I wouldn't take this as written in stone. We do have patients that are discovered more than 6 months, and they have responded to ACE inhibitors, beta blockers, and other treatments. But the point of this is that it's much less likely if it's delayed discovery of their cardiotoxicity. Are there any other strategies to prevent cardiotoxicity? There's been some studies with ACE inhibitors and beta blockers in a prophylaxis sense. Those have been mainly small studies, 70, 80 patients max, and the data on that is not clear. This is a study using dextersoxane, which is an iron chelator that's been found to be cardioprotective. So this prevents the formation of anthracycline iron complexes and the generation of free radicals that lead to oxidative damage. But consistent with the topoisomerase theory, it's also been recently found to bind topoisomerase 2 beta and inhibits the doxorubicin-induced DNA breakdown. So there are mechanisms for why this might work. Currently, it's FDA restricted for patients with advanced or metastatic breast cancer who've already received anthracyclines in a particular amounts of doxorubicin more than 300 milligrams per meter squared, or epirubicin more than 540. And you can see if you have dextersoxane, I don't know if you can see it very well, versus controls, there's a decrease in cardiac events, and there's also a decrease not only in survival, there's an increase in survival in cardiovascular events in patients that received the dextersoxane versus control. Now, why is it not used more often? One is because there has been one study that showed that it might render the chemotherapy less efficacious, and that was done in the early 90s. Since then, there's been a large Cochrane database review that debunked that, but there's still a concern among oncologists that there's a possibility that it might interfere with their chemotherapy. So really, there is a need for novel biomarkers, and really this is a position statement from the European Heart Failure Society that the identification and validation of reliable biomarkers for the prediction and detection of cardiotoxicity to non-anthracycline agents is urgently required. The use of simple biomarkers such as troponins, BNP, should be strongly considered, but it's not a substitute for objective evaluation by echo or similar modalities. So we are also doing studies here where we're following patients that are receiving anthracyclines, and we're getting serial biomarkers. We're getting BNP and troponin in addition to echo with strain, but we're also looking at the possibility of novel biomarkers as well. So this, for patients getting breast cancer, we're getting before and after cycle 2 and 4. There's some evidence that troponins, for example, are unlikely to be positive before chemotherapy, but are more likely to rise within 3 days after chemotherapy. So with that in mind, we're getting biomarkers both before and after chemotherapy at cycles 2 and 4 and at other various time points. And the biomarkers we're looking at are twofold. One are nanopeptide biomarkers, and particularly hepcidin. But we're also looking at the main thrust of our focus is on biomarkers of gene expression. So working with our colleagues in the RI, and Kai-Fu Chen and Leif Peterson, we are looking at RNA sequencing as our biomarkers. We're collecting in blood samples, peripheral blood, in RNA-compatible tubes. We're looking at RNA sequencing that's able to look at a patient's complete set of organized transcribed genes and also non-coding RNAs, such as microRNAs. Compared to microarray analysis, the RNA sequence has higher sensitivity and really is better capacity for discovery of new transcripts, and it's being used more and more than microarrays these days to help discover new for biomarker discovery. So we've so far, as of a month or two ago when we made this slide, we had 94 patients enrolled. We've been doing this for 2 years. And out of these patients, 58 have breast cancer, 28 with hematological malignancies, and 8 other. This really anyone receiving anthracyclines. And so far, we've had, you see in the red, the number of patients that have completed the full year of study. So we have a lot that are continuing to be ongoing. So far, 23 patients have completed a year, and 3 of those have had clinical heart failure. And if you look at, so we've had many that have had just a change in GLS, many, 13 that have had a change in their GLS. But those that have had a drop in EF plus GLS, we've had 3 patients with symptoms, have been 3, and then 4 patients with EF and symptoms without a change in their GLS. And there's 2 patients that died before they finished the 6 months, and really before we were able to get complete data. So so far we've been able to enroll, I think, an additional several patients since then. So we're above 100 patients, and we're hoping to get at least, we're not hoping to get anyone with cardiotoxicity, but if once we get patients, about 5 to 10 patients with cardiotoxicity that's pure in terms of drop in EF and not just strain, then we'll be able to analyze data. In addition, so moving on from anthracyclines, looking at some of the other common agents that can cause cardiotoxicity, Herceptin 2 antagonists are another field of agents. I'm sure everyone here is familiar with them. It's about 20% of breast cancer tumors will overexpress human epidermal growth factor 2, which is associated with the worst prognosis. So monoclonal antibodies against HER2, including Herceptin, have really led to a paradigm shift in the treatment and have been used more often in the adjuvant setting or metastatic setting. In addition, there are newer HER2 antagonists that have been developed and studied in the last few years, particularly pertuzumab, lapidanib, and adotrastuzumab eptansine, which is TDM1. And this is already a very old slide, now 7 years old, but just to give you an idea, at the time this was published in 2012, just how the incidence of the use of these agents were on the rise then, and you can only imagine how much they are on the rise now, but I don't have that slide for you. So the Herceptin cardiotoxicity, it's typically reversible and typically does not cause myocyte necrosis. However, there are a sizable minority of Herceptin patients that do have irreversible heart failure. And so it's about 15% of patients might not recover their function with Herceptin. Most patients, if you simply stop the agent and or put them on medications, they'll recover. But I think people should be aware, because there's not a lot of awareness, that there are a decent minority of patients that will not recover. So the incidence used to be as high as 27% until people discovered that if you separate it temporarily from adriamycin, that the incidence is much, much lower. So randomized clinical trials shows that it's associated with an absolute increase in heart failure incidence by 1.6% if you separate it from anthracyclines, and abnormalities in LV function by 7.2%. But these trials really, as they often do, will exclude older patients and those with more comorbidities. So if you look at what happens in the real world, and this is looking at a Medicare database with women over 65, and why this is important, because 41% of breast cancer patients are over 65, the incidence is remarkably higher. So if you see from looking at the controls, 7.7% of patients with heart failure, the cumulative incidence at 1 year in patients that are on both anthracyclines and Herceptin, 22%, 9.8% with anthracyclines alone, 16.7% with Herceptin. It's really it's much higher in patients that are treated in real life than in the literature. So it's always have to take the initial studies with a grain of salt. And regarding the novel HER2 antagonists, they generally have a more favorable cardiotoxic profile, Although patients with TDM1 and olipidinib have really been limited in terms of the sample size of the studies, and the patients, as usual, have been carefully selected. Pertuzumab is another new agent. It was studied in the Cleopatra study. It was studying the efficacy of two Herceptin antagonists, of pertuzumab plus trastuzumab and docetaxel versus placebo, trastuzumab and docetaxel in patients with HER2-positive breast cancer that was metastatic as first-line agent. The dual HER2 antagonism led to improved progression-free survival without an increase in cardiac adverse events. And we're not going to cover all the agents that can cause cardiomyopathy, but I wanted to touch on kind of the big ones. And so the other class that is underappreciated, but now is becoming more appreciated, and there's more studies in this field is on other tyrosine kinase inhibitors. So we know that deleterious kinase activation is a key pathway in various types of cancer, especially CLL, renal cell carcinoma, GI stromal tumors, and others. And kinase inhibition has been an effective treatment strategy with these targeted therapeutics. However, kinases are also vital to cardiac and vascular hemostasis, and there are often off-target side effects. These are just some examples of the common TKIs that are used. So there's the BCR-ABL TKIs, commonly used for CLL. There's epidermal growth factor receptor TKIs, and then the VEGF TKIs. And this is a nice review from the New England Journal in 2016, and looking at the types of TKIs and how we target these pathways. So at the top, you have the monoclonal antibodies that act against the ligands for the kinase receptors, and in the middle here, you see the small molecule inhibitors that have off-target effects, and then here you see the VEGF signaling pathways such as Avastin, and at the bottom you see tyrosine kinase inhibitors with anti-VEGF activity, such as sunitinib is one of the classic examples that's commonly used for renal cell carcinoma. So VEGF toxicity, especially TKIs, we know that they cause hypertension very commonly. Blood pressure on average increases 10 to 20 millimeters per mercury systolic and 5 to 15 diastolic, and this can occur within hours of starting therapy. This hypertension is associated with proteinuria, therefore ACE inhibitors and angiotensin receptor blockers are very good agents for this. The mechanism of why it causes hypertension, some of it is due to the fact that we know VEGF is involved in nitric oxide production and also prostacyclin production, which are vasodilators, so inhibiting this causes more vasoconstriction. We also know that VEGF will decrease the vasoconstrictor endothelin-1. Independent of hypertension, there's other cardiovascular effects that occur commonly, including heart failure. So this is another example where when the TKIs came out, that the initial incidence of heart failure was very low, about 1 to 2% in the studies with, for example, sunitinib, which you see here. This study was from Stanford, a single center study, but where they have a robust database of patients that are receiving these therapies for renal cell carcinoma, and they had 159 real-world patients and tracked them with serial echoes and biomarkers. And you see in real world, it was a vast increase from what's reported in the initial studies, with an incidence of decreased LVF more than 10%, of as high as 11% in the sunitinib group. And if you look at all the cardiotoxicities, the blue is the light blue is any cardiovascular toxicity. This is predominantly driven by hypertension in the purple, but you can see that the non-cardiovascular toxicity in the green is also pretty robust, and the darker blue is any EF drop more than 10%, so not an insignificant number. So this study, looking at their definition of adverse events, if you see in the top right, for heart failure, grade 2 is anyone with symptoms. Grade 3 is severe with symptoms, and for ejection fraction decrease, grade 1 is undefined, but grade 2 is an EF in the 40 to 50% range with a drop of at least 10 to 19%, and grade 3 is more than 20% drop in an EF in the 20 to 39% range. So if you look at grade 2 in terms of EF dropping, with all these therapies, 10%. and with grade 3, which is a major drop in your EF, up to 4%. And similarly for grade 2 heart failure, about 3%. So really, this is a story that remains to be told in terms of the cardiotoxicity of these agents, but and the monitoring and the screening of these for patients on these agents is not well defined or clear from the literature. In addition, just this one slide just shows that the second generation agents may have a higher incidence of myocardial infarction than the initial first degree agents. So this study was probably not powered enough to make this determination, but it is at least hypothesis generating that the newer second generation agents might have more vascular toxicities. These are just some of the spectrum of the wide spectrum of vascular toxicities you can see with agents such as these, including pulmonary hypertension, stroke, Raynaud's phenomenon, thromboembolism, coronary disease, and heart failure. Looking at, this is a nice review from Circulation, just looking at the types of toxicities with these agents. You can see they're very frequent, causing angina and hypertension, as well as an increased risk of myocardial infarction. And with the tyrosine kinase inhibitors, you can see hypertension, angina, MI, and stroke, as well as DVTs and PEs are also possible toxicities. And then the last class that I want to discuss is the immune checkpoint inhibitors. This is another emerging story and another type of chemotherapy that we're going to be seeing much more frequently in the coming years. How this works is this is one type of agent. So you have normally a tumor cell will protect itself against T cell death. You have programmed death ligand 1. It sounds like something out of Star Wars, like the Death Star. But you have this ligand that blocks the PD-1 receptor on a T cell from attacking the tumor cell. And what the new therapies do is they either block the ligand or they block the receptor and allow the T cell to attack the tumor cell. Similarly, you have this B71, B72 ligand that attaches to the CTLA4, which is cytotoxic T cell lymphocyte antigen associated antigen 4. And if it blocks that, also prevents the tumor from being attacked by the T cell. But if you block either the ligand or the receptor here, you can allow the T cell to attack the tumor. And you can see this is a billion-dollar industry, and it's only going to increase with the use of these agents that's exploding on the market. But what happens when you allow your immune system to have more leeway? Obviously, you have immune side effects, and one of those could be in the heart. This is a paper by Johnson et al. The senior author was Javed Moslehi. He will be here next month at our research conference. And this is from New England Journal of Medicine, showing that especially with combination immune checkpoint blockade, that there's you can have fulminant myocarditis. So there's ipilimumab, which is an anti-CTLA4 antibody, and nivolumab, which is an anti-PD-1 antibody. They're both individually have improved outcomes in melanoma. And this notes that they found 2 patients that had fulminant myocarditis, and that ended up being fatal. And you can see here the very robust immune response in the heart. Due to these cases, they interrogated the Bristol-Myers database with all the limitations of doing so in terms of not being able to, have, you're just limited to database diagnoses. But with this, they saw with single agent therapy, you had an incidence of myocarditis that was about 0.06%. If you use both agents together, it was about 0.27%. This is probably underestimated. And looking at the mechanisms that are potential mechanisms, you see that PD-L1 expression in the heart was increased in these patients. And in particular, PD-L1, if you looked at the gene expression of PD-L1 in the heart compared to other organs, it was vastly increased. And the theory is that perhaps PD-L1 increased expression is a defense mechanism against the immune response, but it's not known. So there's been a lot of subsequent case reports about immune checkpoint inhibitor toxicity. This one is a case series that was in Circulation earlier this year, and it took the combined characteristics of 12 patients that had cardiotoxicity from their 2 cardio-oncology centers, plus it took 18 patients from previous report from other case series. And very interesting clinical phenomenon. One is that this was diagnosed at a median of about 65 days from the start of the infusions, and after a median of 3 infusions. If you look at the particulars of the patients, what's really interesting about this is, one, it's not the dual immune checkpoint inhibitor from the New England Journal article was only 23% of these patients. Most of these patients were on single agent therapy. And in terms of what we need to know for diagnosis is, one, LV dysfunction was common, as was arrhythmias were relatively common as well, and conduction abnormalities. Symptoms, most patients had dyspnea. An EF drop was, the median EF was 35%, 12% were less than 35. And in terms of making the diagnosis with patients with myocarditis, interesting that late gadolinium enhancement on MRI, only 23% of these patients had late gadolinium enhancement. However, those that had biopsies, here, 9 patients, 8 of them had lymphocytic infiltration. So the biopsy was unlike classic myocarditis. These biopsies, where MRI is much more sensitive and the biopsies less so, in this case, the biopsy was much more sensitive than the MRI. So the challenge of this diagnosis is really going to be tough. A lot of these patients have thrombocytopenias, et cetera, making a biopsy challenging. They're sick patients typically. And if they can, MRI may not be the gold standard as it is in other causes of myocarditis. And that may be because of the early diagnosis, even with classic myocarditis, MRI in the first few weeks of diagnosis may not show up. And most of these patients are treated with steroids and holding of the checkpoint inhibitors, and a lot of them do get better, but some certainly don't. This is just a list of the FDA approved immune checkpoint inhibitors, and the indications you can see here are various, and they're only going to be growing, and we're going to be seeing a lot more of these on the market. And then I just wanted to touch base briefly on radiation therapy and the various side effects that can occur from radiation therapy. This is also from the recent JACC state-of-the-art review. But radiation therapy can commonly cause pericardial disease. It can cause acute pericarditis. It can cause constrictive pericarditis long-term, as well as chronic effusive constrictive pericarditis. Coronary disease, we know that it can cause endothelial dysfunction as well as fibrosis and cause long-term coronary disease. There are some programs that are doing stress tests or coronary CTAs 10 years for asymptomatic patients that have had radiation therapy. Valvular heart disease is also very common, especially regurgitant lesions. For some reason that's not clear, although the radiation is anterior, the left-sided valves seem to be more commonly involved in the right-sided valves. Conduction abnormalities also occur, and then cardiomyopathy can occur. It's more often diastolic dysfunction can occur from radiation therapy. And then this was a landmark study from New England Journal of Medicine showing that every increased gray of radiation to the chest will have a 7.4% increase in major cardiovascular events. The average dose in this study was 4.9 grays, and the average dose for breast cancer in the present era now is about 1 to 5 grays. So this was a very important study. Modern techniques we're hoping will decrease that, but it's not clear that it has yet, and it'll take years to really determine that. But these techniques include a deep breath hold so that you can get the heart out of the pathway of the radiation, proton radiotherapy, 3D planning, etc. So our program formally launched in March of 2017, and I have to say this quote, this mantra to myself every day. We're starting modest beginnings, but we've really, the inpatient volume has been very high, and the outpatient volume has been, starting from nothing in March, it's been steady, but we're hoping to certainly grow that. Our team, this is our cardio-oncology team. We have Wengrid, who's our nurse practitioner. We have Yvonne, who's our medical assistant. We have Rachel Arujo, who's our research fellow, who's done gotten all the patients for all the studies we're doing. Our research program is, we have 3 active trials. The first one is the anthracycline transcriptomic and nanopeptide biomarker study that we're doing prospectively. The second is we started a heart rate monitoring with the wearable devices as an early predictor of cardiotoxicity in patients with breast cancer on anthracyclines. We just started enrolling in that study a few months ago. And then finally, we're taking patients that have known anthracycline cardiotoxicity and doing whole genome sequencing of these patients to determine if there's a genetic predisposition. And then other parts of our cardio-oncology program, our cardiac amyloid program, which was started several years ago by Jerry Estep. Really our transplant experience with amyloid is one of the largest in the world and is the largest multi-organ experience for AL amyloid. Since we started the program, we've done 5 transplants for TTR amyloid. 4 out of 5 of these had heart liver, and 3 of those had abdominal liver that they were able to give to patients that were on the alternate wait list for liver transplant. We've done 17 transplants for AL amyloid, including 2 heart kidney and 2 heart lung. And if we exclude the heart lung 2 patients, one of which is alive, one of which isn't, and heart lung generally has a worse survival than the other multi-organ transplants. If you take away those 2, then our 5-year survival for cardiac amyloidosis is among the highest reported, 78%, and 75% for AL amyloid specifically. This is really, compared to what their survival would be without it, we're very proud of these numbers and are looking to publish this shortly. But this is really takes a lot of collaboration with hematology, bone marrow transplant, nephrology, hepatology, pulmonology, and of course our surgeons. And then also just one other thing we've noted is that if we looked at our advanced heart failure patients with cardiotoxicity, generally from other databases, we know that 2 to 3% of patients with non-ischemic cardiomyopathy that undergoing heart transplant have chemo-related cardiotoxicity. Looking at the databases, we took a look at our, over 3 years, 553 patients that instead of looking at databases simply that were referred for evaluation for LVAD or transplant. And we found that 8% of all non-ischemics had cancer-related heart failure, mostly was anthracycline patients. But what's interesting is if you look back and look at these patients and how they were submitted to UNOS, our transplant database, or INTERMACS, which is the LVAD database, a lot of these patients were misclassified imprecisely as just having an idiopathic DCM. So we were looking at just our one site, we were able to correctly change the classification of 60% of these patients for transplant and 40% of the patients for our LVAD database. So this is shows that in the databases that are the national and international databases probably underestimate the extent of this disease. And if you look at our outcomes for these patients, whether they had other types of heart failure versus heart failure related to cancer therapies, whether they've gone for, you think they might be sicker, have more comorbidities, but they've been able to go for LVAD or transplant in higher percentages than the other patients, and their survival is actually excellent on all those modalities. So we've been able to, we want to try to avoid having these patients and detect them earlier and prevent this from happening. But in some cases where it's unavoidable, we do have outcomes for these patients. So just to conclude, as the number of cancer survivors and the type of chemotherapies increase, there will be increased number of patients with cardiac side effects from these therapies. Anthracyclines are a common cause, but if detected early and treated early, patients can recover. The cardiotoxicity of many agents, including TKIs and VEGF inhibitors, were underestimated in the initial trials. Immune checkpoint inhibitors can cause fulminant myocarditis in what appears to be small numbers, but more investigation is underway and needed. And finally, increasing collaboration between oncology and cardiology is really critical to improving outcomes and to improve survivorship for cancer patients. And thank you for the attention, and thank you for everyone that helps support this program. I appreciate it.
Thank you very much for this very comprehensive review. Tells us that there are so many things we don't know as cardiologists. I mean, all these newer therapies and things, and it also tells us that we need some specialists in this area to help the oncologist as well as the cardiologist manage these patients. Questions from the audience?
Barry, thank you for a really great review. It's great to have this at this hospital. You know, it's interesting. We're right next to one of the world's best recognized and largest cancer hospital, and we often don't think about ourselves as a cancer hospital, but Methos Hospital is the #2 lung cancer site in Texas. And so it is interesting to see this coming along. One thing that I'm really worried about as we go forward is I look at the sarcomas that I take care of. As they move past the standard adriamycin phosphomide, everybody's going to T-cell immunotherapy right now. And I'm worried that the myocarditis rates that we're reporting are going to be much lower once we're 5 years into this. Have you had any of your patients come back with myocarditis yet?
So I've had 2 patients that have had drop in their ejection fraction on Opdivo. One of them was very sick, had a severe thrombocytopenia, unable to do a biopsy. Did an MRI a month later, that was negative. But I still think that's what he had. We have another patient that had a more insidious drop in EF, but after the first couple doses, dropped his EF to about 35-40, and he's remained there in the last year. The family doesn't want to pursue a biopsy. MRI can't be done because of his GFR is less than 40. So we have had 2 patients, and it's challenging to diagnose. As you can see, the biopsy seems to be the best method of diagnosing, but these are patients with fulminant myocarditis predominantly. So for my patients, that one patient with the chronic heart failure, a biopsy might not be fruitful. So it's a challenge.
Very great overview, thank you. Just in terms of the immune checkpoint inhibitors, I'm sure you're aware of, that the corticosteroids and Prograf both act on PD-1, and they do definitely upregulate PD-1. But also in the statins are known to upregulate PD-1. Though not as much as Prograf or steroids. Any thoughts on whether in these studies, patients who've been on low-dose steroids or on statins have had protection from having adverse cardiac events?
So it hasn't been looked at. That's a great question. I don't know if with the numbers that have been reported, if there's going to be enough numbers to look at that. But going forward, that might be something that's worth looking at. I know that some centers are looking at IVIG as opposed to steroids, but I don't know of anyone else looking at other therapies.
Great overview, thank you. Question, I'm not sure if I missed it. Has there been any data looked for the patients who do not drop their EF but decompensate regularly or develop heart failure with preserved EF? That's one I want to know, because I have a patient who had a concomitant diagnosis of severe CAD. So she lives in an EF between 45 and 50, but she decompensates frequently with Herceptin and then stabilizes. Her EF never drops below that point.
Yeah. Yeah, no, these are tough patients to manage. I mean, particularly with anthracyclines, it's known that they can cause diastolic dysfunction as opposed to systolic dysfunction. So it's certainly potentially possible with the Herceptin too, but I haven't seen any reports of Herceptin causing specifically diastolic dysfunction. But these patients get a high dose of IV fluids with their chemotherapy, and certainly that can contribute as well.
Great talk, Barry. 2 quick questions. One is, people who drop their EF, they're treated and they recover. Completely recover, they're happy. Years later, can they be at more risk for other types of cardiomyopathy? I have a patient that actually, that happened 20 years ago, totally recovered, and then 20 years later, presents again with a low EF and heart failure, and actually recovers again for the second time. But are they more at risk?
So we suspect so. I mean, at least taking the patients, not cancer related heart failure, but other patients that have, quote, heart failure with recovered EF, we know that they're more likely to have heart failure down the road, even though their EF is recovered. So they're never quite normal. I suspect it's the same with the patients that have had anthracyclines.
Sort of heart failure, quote unquote, therapy for life? Is that?
I would keep them
kind of
on.
under
Yeah, those patients I typically keep on ACE inhibitors, beta blockers for life.
Second question, is the oncology community across the country beginning to buy this? Or are we still having issues, not here at Methodist or MD Anderson, but across the country?
I think so. I think there's more recognition. So at the major society level, they have sessions, particularly on cardiotoxicity at the Oncology Society meetings. So I think it's certainly improving. I think the struggle is, it's not only the communities, but particularly when you go to communities and they don't have methods or the wherewithal necessarily to screen patients regularly and follow them. And there's also, among cardiologists, there's many cardiologists. I mean, it's a dizzying field to keep up with. There's a lot of room for improvement within cardiologists as well to recognize that an EF of 50% when it started out at 65% is not normal. And that's an opportunity to intervene. So.
Great talk, Dr. Trachtenberg. I have a question regarding the medications used as prophylactic agents for cardiotoxicity induced by chemotherapy. Specifically, Dextersox and all the iron chelins are used right now. What's your experience on using those, and what's the success rate of those prophylactic medications?
Yeah. So our experience clinically, we have used it for patients that have really bad hematological malignancies that are getting high dose anthracyclines, or that have had a drop in their EF that's mild, but really have a bad prognosis without further adriamycin or anthracyclines. So we have used it in that setting for various patients. It's hard to know the success that we've had clinically because we've probably used it in maybe half a dozen patients or maybe 10 patients maximum in the last few years. So I can't really conclude on our experience, but I can conclude from the literature that it seems to be protective, but it's not used across the board, certainly. So.
Barry, I have a practical questions for you. One, should we get an echocardiogram or a troponin before every dose of chemotherapy when an individual is undergoing chemotherapy, or is that no?
Yeah. So that's a good question. I think if you have a patient that has risk factors and or getting high dose anthracyclines, I think certainly a baseline echo. And an echo after every chemotherapy is probably excessive. But a biomarker before, but the challenge is it's not only before chemotherapy, but a lot of evidence shows that the troponin, if it rises, is more likely to do so within the first 2 days of chemotherapy. So and that's a challenge. Patients come in, they come in for chemotherapy, they're exhausted and they have to come back to get blood draws within a couple of days of that. That's a challenge to make that happen. So I think I can say for anyone getting anthracyclines at least, we'd certainly want a baseline echo, baseline troponin, ideally one at the time of chemotherapy. And then after they've had about 240 milligrams per meter squared, we typically do another one, and then we'll do one at 6 months and then a year. And I still do it annually for all these patients for at least the first 5 years.
I mean, conceivably, that could be an area of research to identify, when and how should we do this from an overall utilization and prognosis point of view. The other question to you is there a role for prophylactic beta blockers, ACE inhibitors, to use it when somebody is high risk, et cetera, before waiting for a reduction in ventricular function, since they are rather benign, I would say?
Yeah. I think so. I think in terms of using it for everyone, I think I don't recommend that just across the board because there are side effects from medications. They could, if they're dehydrated from their chemotherapy, putting them on ACE inhibitors, beta blockers. However, patients that are high risk, that they have poorly controlled blood pressure, certainly is a good excuse to put them on an ACE inhibitor, beta blocker, or if they have multiple risk factors, age plus strong family history, for example, or I have a very low threshold to use those agents. The studies that have looked at prophylaxis for all comers have shown mixed results, but some of them have shown some benefit. But these are all 70, 80 patients and not strong enough power to make conclusions. But.
All right, with that, I want to thank you for a wonderful grand rounds, and thank you for attending. Happy holidays to everyone. We'll see you next year.